In this third and final talk on CNS pharmacology, we will look briefly at the antidepressant drugs. Before we proceed, I just want to remind you that this just gives a brief outline of the drugs and their pharmacology to help you focus your mind on what is important. You will need to read about all of these drugs in a lot more detail. So again, using our clinical scenario, we will look at the clinical pharmacology of commonly encountered antidepressant drugs and their pharmacokinetics where appropriate. So again, if you remember from the last talk, we had a 45-year-old psychiatric patient who may have taken an overdose of his tablets. We didn't really talk much about the toxic effects of antipsychotics, but they flow directly from the acute CNS and cardiovascular effects of those drugs. Similarly, with the antidepressants, we see a similar relationship. So, thinking about this middle-aged psychiatric patient on antidepressants, what drugs might he be on, and what is the pharmacology of these drugs? So, when we think about antidepressants, we can classify them into these groups. The selective serotonin reuptake inhibitors, which are nowadays the most commonly prescribed antidepressant. The serotonin noradrenaline reuptake inhibitors, which tend to have a similar profile to the SSRIs. The tricyclic antidepressants, a more traditional group of antidepressant drugs, which tend to carry a higher risk of cardiovascular and neurological adverse events and have a low therapeutic index and can have severe cardiac and neurological toxicity, particularly when taken in overdose. The monoamine oxidase inhibitors, which are these days less commonly used because drug-drug interactions are common with this group. And finally, atypical antidepressants, which really don't have any unifying mechanism of action, and there's a different profile for each drug. We're really going to focus on the SSRIs and TCAs. So let's think about the SSRIs. What is their mechanism of action? They block the reuptake of serotonin from postsynaptic junctions in the CNS, but have little effect on dopamine and norepinephrine. They also have little effect on the dopaminergic, adrenergic, cholinergic, and histaminergic receptors. So actually, if you think about this and go back to the talk on antipsychotics, you realize that a lot of the side effects of the antipsychotics have to do with particularly their anticholinergic effects, but also to some extent their dopaminergic effects. These drugs tend not to have such a bad side effect profile. However, they do have acute side effects. They can prolong the QT interval leading to arrhythmias, but this is rare. They do inhibit P450 hepatic enzymes and therefore can interact with other drugs that are metabolized by this enzyme system in the liver. They can acutely cause serotonin syndrome, which we'll discuss in more detail, and they are contraindicated to use with monoamine oxidase inhibitors. Chronically, they can cause sexual dysfunction, sleep disturbances, weight changes, anxiety, dry mouth, headaches, and gastrointestinal distress. Of importance, they can increase the risk of suicide in young adults and adolescents, and this needs to be monitored when this group of patients is put on SSRIs. So, let's think a little bit about the diagnostic criteria for serotonin syndrome. And these can be divided into major and minor symptoms, and these symptoms may be mental or pertaining to mentation, autonomic and neurological. The mental symptoms, the major mental symptoms are coma, confusion or elevated mood. Autonomic major symptoms include fever and hyperhidrosis, and neurological symptoms can include chills, hyperreflexia, myoclonus, rigidity, and tremors. There are lots of interactions with SSRIs that may contribute to serotonin syndrome. And I'd like you to pause the video and see if you could think of some of them. Again, it's the kind of thing that can come up in exams. So here's a long list. Various analgesics, most other antidepressants, dopamine antagonists as you would expect, triptans, some herbal and nutritional supplements, drugs of abuse, and other miscellaneous medication. So this is a fairly long list, and it's worth just thinking about the main groupings and some of the more common drugs that people may be put on or may be on in conjunction with their SSRIs. What about the tricyclic antidepressants? Well, these drugs have acute side effects on the CNS, including cerebral irritability, mental confusion and coma, seizures, pupillary dilatation, hyperreflexia, and cardiovascular effects including tachyarrhythmias. They can predispose to torsade de pointes, hypotension, and then other effects such as dry skin and mucous membranes, hyperthermia, and chronic side effects such as extrapyramidal side effects and anticholinergic effects. Now you notice we didn't talk about the mechanism of action because that has a direct impact on what toxicity looks like. So when we're thinking about Tca toxicity, we need to think about all the different actions of the drug. They inhibit norepinephrine and serotonin uptake, which can lead to tachycardia, confusion, seizures, and coma. They have an anticholinergic effect, which can cause tachycardia, dry skin, urinary retention, and again confusion. They actually have direct alpha-adrenergic blocking effects, causing vasodilation and hypotension. And they can also block fast sodium channels, leading to wide QRS complex, membrane stabilization, and ventricular excitability. So you can see that the toxic effects of tricyclics are very closely related to the mechanisms of action of the drug. Again, this is something that does come up in your exam. So again, if you have any questions or comments, please feel free to bring these up in class and we'll talk about them. Just to remind you, in these 3 talks, we looked at anti-epileptics, particularly those used in status epilepticus, antipsychotics, and antidepressant drugs. Thank you.